Well, I've shared with you quite a bit now on the problems of CPR performance and difficulties with CPR quality. Well, I also showed you that we can record CPR using certain defibrillators that allow such recording. Our group and other groups have shown that using these CPR defibrillators, you can actually give feedback to rescuers and improve quality. These defibrillators actually can give real-time feedback, so you can actually look at the video screen on the defibrillator and see your rate, see your depth. And this sort of fits into a schematic where you might imagine we deliver CPR, we record CPR, we give feedback, and then we do it again. And this is a cyclic process by which you could improve care over time. Well, one of the other ways we might consider improving care that's very much a current discussion in many hospitals and EMS settings is, can we use debriefing? After all, if we're going to record CPR, which I would argue all hospitals and EMS agencies should really consider doing, if we're going to record CPR, we could use that information to train people and say, well, gee, you did CPR, here is your CPR, let's talk about how you could do it better. Well, we tested this model in the hospital setting where we took teams of physicians that provided CPR and debriefed them on their own cardiac arrest events, meaning we'd sit them down and say, you guys worked this cardiac arrest or provided CPR, and we want to show you what you did and talk about ways we can improve. And what we found was when you do this, you actually can improve outcomes. So in that third column, feedback plus, the CPR is giving, the defibrillator rather is giving CPR feedback, and we're doing debriefing. And this is the rate of ROSC, or return of spontaneous circulation, in this group, which is much higher than a baseline or when we turn on the feedback defibrillators. So debriefing plus CPR feedback improved survival in this study. We've studied this in the simulation laboratory. A fellow working with me, Dr. Jessica Dine, has done important work on this, as have other groups. The point being that there's a lot of ways we can improve the culture of resuscitation, both for pre-hospital providers and hospital providers. Now, to set some context for this, you might wonder why I'm being such a CPR zealot. Those of you who are expert providers know that, well, there's medications and epinephrine and other drugs that we give during cardiac arrest, and isn't that more important? We call it advanced cardiac life support. Shouldn't it be more important than basic life support, which is CPR? Well, funny that you should ask that question. ACLS, which is the standard model for care as given by most advanced healthcare providers in the hospital and pre-hospital environment, does indeed use these drugs. And indeed, the American Heart Association guidelines say for all cases of cardiac arrest, providers should give epinephrine every 3 to 5 minutes during a cardiac arrest event. So you might say, epinephrine must be really important, right? Maybe it's more important than CPR. Well, that's epinephrine. Those of you who are not healthcare providers should know when I say epinephrine, you may think adrenaline. They're the same thing. Those are synonyms. Adrenaline is the more publicly known term. This is a natural hormone made by your body that's sort of a fight or flight response. It gives you great amounts of energy, dilates your pupils, makes your heart beat faster. You release this every time you sit down for an exam at school or every time you have a near miss driving. If someone swerves into your lane, you release epinephrine. So it's a well-known, well-studied molecule that has dramatic effects. But you should know this. A really well-done randomized controlled trial out of Norway looked at whether or not epinephrine improved outcomes in cardiac arrest. Now, those of you who are healthcare providers may say, why does this get studied in 2009? We've been giving epinephrine for decades. Well, sometimes we have to go back and look at what we believe to be true to see if it really is true. And believe it or not, epinephrine had never been studied in a randomized placebo-controlled trial until 2009. It was studied in paramedic ambulance settings in Norway. Half the patients got standard care with epinephrine being given during cardiac arrest, and half did not. They did not get any epinephrine. They only got CPR. Well, surprisingly, perhaps to some of you, epinephrine did not improve survival at all. Whether or not the paramedics gave epinephrine did not affect survival to hospital discharge. Now, I'm not suggesting you don't give epinephrine. There's some reasons why it may be good. It is still part of the guidelines. But this is just to set the context that the medications we all as physicians and ACLS paramedics believe to be so important, they may not be as important as the basic fundamentals of doing good CPR. The evidence supporting good CPR is much greater than the evidence supporting any of these drugs that we call advanced cardiac life support. Now, in a lecture on CPR, I would be remiss if I didn't talk about some of the new devices coming out to deliver CPR mechanically rather. I shared with you the manual CPR support devices, and these are two such devices that allow you to monitor and deliver CPR. There are mechanical devices as well, where you put the patient in these devices and you hit a button and the machine provides the CPR. Therefore, it might be perfect, right? No human required. Well, I'm going to share with you some data on one of these to show you that it's a bit more complex than that. This is a device called the AutoPulse device, and again, full disclosures, I've received no funding from AutoPulse, and I have no equity or intellectual property in any of these devices. This was a study done using the AutoPulse device in Richmond, Virginia. Paramedics were given these devices, and resuscitation care outcomes were recorded both in a period of time before they had the device or when they were doing manual CPR versus after they got the device or when they used AutoPulse. And they found that survival to hospital discharge tripled when they used the AutoPulse device, suggesting that AutoPulse may have provided great CPR and may have saved many more lives in the city of Richmond. Now that sounds fantastic, right? This is a randomized controlled trial in 5 cities that looked at the same thing, manual CPR versus AutoPulse CPR. And what did they find? They found that survival was the same, and if anything, you see they're lower in the AutoPulse study. Statistically, I'll tell you it's not lower, it's sort of a wash. It wasn't clear whether manual CPR or AutoPulse were any better. I share with you this just to show you the complexity of clinical research, that you can have several studies looking at the same question, finding different results. Why is that? Well, the devil's in the details. The way you design the study, the way you train people to use these new devices, the way you record your data. Suffice it to say that in the year 2012, we don't know for sure whether mechanical CPR devices are good in all situations with all providers. It's an area of great interest. Many ambulance systems and even hospitals are starting to use mechanical CPR devices, and we'll learn much more about this, I believe, in coming years. Now, I talked a lot about laypeople CPR in terms of not using breaths. Can we use similar techniques for professional rescuers? This question was asked by a colleague of mine, Dr. Ben Bobrow in Arizona. He convinced his paramedics to not give rescue breaths and not defibrillate patients until 200 compressions were delivered. This was done in the state of Arizona where he works. And for some time now, the state of Arizona has actually been a great leader in the world of out-of-hospital CPR quality. What they did in this study, and indeed in current day practice in Arizona, is they do not intubate patients and they do not breathe for patients until they've delivered 200 compressions. The idea being this is sort of like hands-only CPR, at least for a period of time. And what they found was survival greatly improved when they used this new protocol. Now, many EMS systems or ambulance systems are starting to use protocols like this, where they de-emphasize breaths, de-emphasize intubation, intubation being defined as when you put a breathing tube in for a patient, to emphasize the importance of compressions. And so we may see great survival gains by using these techniques. It should also be noted that these were simple interventions. There were no new drugs involved here or new devices. So Dr. Bobrow did not buy new defibrillators to do this or use any magic new potion. It was really just an educational intervention where paramedics changed their practice. Now, I say simple. You can only imagine what it is to train thousands of paramedics in a new protocol. But nonetheless, with new education and new knowledge, they tripled survival in the state of Arizona, and in many places in Arizona now, survival is much higher than other places in the United States. So, this leads us to a very important question that I want you all to ask yourself. Call this a homework assignment, if you will. What is the CPR quality like in your community? In your community EMS agency or ambulance corps? In your community's hospital? Do you know? And if you don't know, I would urge you to find out. CPR quality makes a big difference, and many hospitals and many ambulance agencies do not record how we perform CPR. So, said another way, if your loved one collapsed right now, and you called 911, would the EMS providers give excellent resuscitation care? Would they give it care following the Arizona protocol where they delay breaths to give good compressions? And what is the CPR quality like if your loved one were to collapse right now? So keep that in mind, because cardiac arrest happens all around us every day without warning. So we need to ensure that our communities have good quality. So, leaving you with that ominous note, I might suggest the following summary points. that cardiac arrest is not hopeless. We can do things to improve our care and improve survival. That CPR quality has a big impact in the variability of cardiac arrest survival that I presented at the opening of this lecture. We should minimize the ventilation rate that we give. We should maximize the chest compression rate and maximize the chest compression depth. And for those of you who are professional responders, we really should consider using these CPR feedback tools, and we should consider code, or cardiac arrest, that's a synonym, code debriefing. We should consider using tools and debriefing our teams after arrest events. And then, most importantly of all these things, for the lay public, we should make sure that everybody learns CPR. So that concludes lecture number 2, a discussion of CPR quality and training surrounding CPR. Please join us for the upcoming lectures in this Coursera series. In our next lecture, lecture 3, we will be talking about therapeutic hypothermia, an exciting new therapy to be delivered to patients following resuscitation from cardiac arrest. After that, in lecture 4, we will have a guest lecturer, Dr. David Gajewski, a colleague of mine at the University of Pennsylvania, who will be talking to us about some exciting new therapies and the future of cardiac arrest care. Then finally, this lecture series will end with lecture number 5, where we will be discussing issues of survivorship and some of the ethical and end-of-life issues surrounding cardiac arrest for both victims and loved ones. Please join us in future lectures in this Coursera series entitled Resuscitation Care, and we hope you've enjoyed this lecture. Thank you.